Good afternoon, everyone. This is a short discussion on elimination, both bowel elimination and urinary elimination for my Monday class of students. As you know, we don't have a ton of time to go over some of these PowerPoints, and I know by Monday afternoon you guys just look kind of beat. So you can listen to this lecture ahead of time and kind of know what's going on in class. When you come to class, you'll be ultra prepared. So the big question, what am I talking about with elimination? Elimination is removal of waste from your body. Two major types: urinary elimination, excretion of your urine by your kidneys, and of course bowel elimination is excretion of feces by the intestines. Let's start with our kidneys and urinary elimination. I'm not going to review your anatomy and physiology here. If you need to do that, you all use your phones all the time. Go online and look for a good video to review those things with you. You have, starting with your kidneys, the urine goes from the kidneys, the ureters, the bladder, and then to the urethra. Okay, and what's the function of that urine? It's filtering your blood. It makes urine. It excretes bad things from your body. But one thing that I don't get through sometimes for students is you got to kind of assess urine, just like we go and assess a person, or we assess their vitals, or we assess if they're alert and oriented. You also have to assess normal characteristics of urine. What's the color, the clarity? I mean, is it full of junk? Is there an odor? We actually have a tester that you can test the pH of urine. You don't see it a lot. It's a stick that you see sometimes in offices, but they do dip urine and check for pH. That pH can often tell you if you have a UTI. So this is something that you have to start looking at. And I always have to use the thing. You have to look if urine is real dark colored, a person could be dehydrated. If it's real light colored, they're probably well hydrated. You color your urine to kind of detects your hydration status. So what kind of questions am I asking a patient? I ask for subjective data. I ask them if they have frequency, if they have discomfort, burning, how often they go, how much water they drink in a day. What I do objectively is I inspect the bladder area. You can actually palpate the bladder. The other thing we can do is look at some lab tests, which I'm going to go over with you in just a second. The other thing that you can do is intake and output, have really, really strict intake and output monitoring. And I teach fundamental students. I teach seniors too. But for fundamental students, a lot of times the first patients we meet, they don't get a strict INO. And when I start to tell students they need to do an INO as they move along in their nursing career growth, they look at me weird. But think about this: a patient who goes to surgery and might be very, very risk of going into shock, we would want to do a really strict intake and output monitoring. People in kidney and heart failure, we do a strict intake and output monitoring. We look at the urine. That tells us a person who receives, if you give a patient a diuretic to get rid of fluid on them, their urine will start to look almost like water. But it's supposed to. We're trying to get it off of there. They're overhydrated. So just kind of keep that in mind when you're thinking about doing your assessments. The first test to know is a urinalysis. A urinalysis is a set of tests that looks at the urine, and it's looking for like a very wide range of disorders. It looks at the appearance of the urine. It checks for red and white blood cells, checks for protein. It checks for something called nitrates. It's looking to see if you have a UTI. It can also tell if you're dumping glucose into your urine. It can also tell if your creatinine is high and those things in the urine, it may be having a kidney problem. And they can detect that in the early stages. Okay, you do in lab where you learn how to collect what's called a clean catch urinalysis. Everyone should kind of know that. I didn't put a lot of lab information in here, but you need to understand that things do start to overlap. And the reason we do a clean catch is we want to try to avoid getting any extra bacteria in there. We can also get a urine specimen through a Foley or through what's called a straight or intermittent cath. And those are other ways to obtain those specimens, but they all go over. And a urinalysis has nothing in it. When it comes back, it should have nothing in it. Everything should say 0, red blood cell 0, glucose 0, protein 0. If there's something in there, then they start to wonder what's going on. It's kind of a way to assess a person and see what is going on with them medically. In addition to urinalysis, you can have blood drawn, and you can have what's checked is called a BUN and a creatinine. A normal BUN is always under 1.3. There's a little way I always remember this, and I think I've seen this online also. A BUN over 1.3, there's a problem with your kidney. And the other one is creatinine. Now, I put creatinine down as 10 to a 20 on here. There are some books that I noted when I was trying to prepare my own material here that it showed it as 10 to 8 to 24. I don't want you to get worked up about that. Sometimes the students go, well, what is it? I got to memorize it. It's for a test. You didn't tell me what it is. I got to know what's on the test. They're never going to give you that normal. They're going to give you somebody with some crazy something that you know right away is out of whack. And I shared this with a group the other day, and I don't remember if it was your group or not. But if anything's really, really crazy, they'll call you from lab with what's called a critical value. A critical value would be if white blood cells are really, really high. And they don't, and some of you say, well, don't they put this in the computer? They do. The lab will put everything in the computer, but it may take them hours. So if there's anything totally nuts, crazy in lab work, they call and talk to an RN at the hospital. I have seen them talk to LPNs at nursing homes and other facilities. So it's something to keep in mind. These two tests is BUN and creatinine or BUN and the creatinine are waste products that come out of your kidneys. So when we measure the level in your blood, it kind of lets us know what your kidney function is. One thing that all nurses know, and I know you guys have heard me say before, stuff all nurses know about Sanka, is how to care for a Foley catheter. A Foley catheter is a flexible tube. It goes through the urethra into the bladder to drain out urine. I've also heard indwelling catheter because this is actually left in place for a period of time. There's a balloon in there that's filled with sterile water that holds everything inside the bladder. The urine drains out through the tube. So this is really you think about this, you meet a lot of people with Foleys. A lot of times they put them in surgery, but something kind of interesting happened, I'm going to say in the last 20 years. We started realizing that a lot of our healthcare acquired infections were coming from Foley catheters. And a term came up. I actually put it in the notes. It's CAUTI, C-A-U-T-I, and that stands for catheter-associated UTI. And when they started looking at healthcare-acquired infections to try to improve healthcare in the United States, a lot of it went back to people with Foleys in and poor insertion from the nursing staff, which we need to take responsibility for that. So when we used to see Foleys be put in on a lot of patients all the time, they say, oh, just put a Foley in. You don't see that as much anymore. And you see more of people focusing on keeping this sterile and only using this Foley catheter if they have to. Okay, and you got to remember this is sterile, and this risk of healthcare acquired infections here really, really high. The bladder is sterile. This has to be sterile. And when you learn sterile technique, which you need to know and you should know, this is put in sterilely. And I would say we've had some practice changes on this insertion over the past few years. There was a time when we used to pre-inflate this little balloon here, this balloon that's right here. We used to go and practice and make sure that the balloon inflated before we put the Foley in, and we found out that that was contributing to infection risk, and we no longer do that. But a lot of times when I'm out, I still see nurses who inflate that balloon. I'm not sure why we're slow to change our practice, especially when it benefits the patient, but you might see that. But we no longer have to do that. Like I said, we try to keep this Foley in as little as possible. We get patients up right away and get them in to try to urinate on their own without a help of this flexible tube. So here's a picture of what I always call this a straight catheter, but it's actually technically called an intermittent catheter. It is a thin, flexible tube that you use to drain urine from the bladder, but when the person cannot urinate on their own. It goes up to the urethra, and once the bladder is empty, this catheter is removed. Unlike a Foley, there's no balloon here. We don't leave this in place. You will meet people that catheterize themselves at home several times a day with one of these. I have seen where they're reusing them at home because they don't have money to buy them. This is a very high risk for infections. And you're supposed to be able to put one sterilely in every time that you need it. But like I said, I don't think a lot of people who do this at home do that. So just kind of keep that in mind. If I say straight catheter, if you need a urine specimen and the person doesn't have a Foley in, they usually say and they aren't able to give you a urine specimen, they'll say, can you get the urine specimen with a straight cath? So this is kind of nice to do if someone is not able to give you a urine specimen and they're immobile in bed. You can go ahead and straight cath and get the urine specimen right from the bladder and send it over to the lab. So let's talk about female external catheters, or a PureWick. PureWick's actually a brand name. So what are we looking at here? So a female external catheter is non-invasive. It's a way to collect urine on women who have incontinence issues. or they need assistance with urine output management. It's got a little soft, flexible wick. Well, it isn't actually little. The wick is here, and you can guess where we sit the wick. We kind of place the wick, and this machine is hooked to suction, and it pulls. Um, this sheath is placed, it's actually externally up near the vulva, gets the urine and brings it back to this canister. This is pretty much standard in a lot of facilities now with incontinent women because we had such 3 or 4 reasons. One was when we put Foley's in, we're inducing a bacteria when we do it, and a lot of people were getting healthcare acquired infections. Second of all, every time a person is incontinent, they're risking pressure ulcers. I don't know if you realize this. This does go back to kind of a financial issue. If a person gets a pressure ulcer, the cost of their care goes up. If they get a UTI, the cost of their care goes up. We're adding to the problems in the healthcare environment. So this was kind of an incredible thing when it came out. This is the one for the women. I'm not going to lie to you. I've had to explain what it was to several older women who were slightly confused. I'm not sure what they thought I was doing when I was trying to place it, but I don't mean that bad, but that's part of the job of being a nurse. And this is now actually sold where someone can buy it at home if they have it. Like if you're caring for a grandma at home and she's incontinent, you can get this, and then they can sleep through the night. They're not getting up and falling. So this was kind of an incredible thing when it came out. So interesting information is they do make a male external catheter. PureWick now makes one that is similarly set up like this one that I have there in the picture. And something for you to know just on the side note, if I make my own material, I have to kind of find free pictures. So sometimes they're not free. But basically what you're looking at for a male external catheter, if we're going to put something in that does not go inside the bladder and risk infection, this is also called a condom cath. It actually will roll down. You're not supposed to, they always talk to you about not taping it around. You can have this drained directly into just a simple bag, or they do make a PureWick model of this now. I would say to you that this is a little difficult sometimes when you place it on men. It depends on the man and his history. It depends on his, this is more of a size thing, so you gotta be able to get this on and be able to keep this on there without it falling off. And a little bit of sweat sometimes makes them fall off. I actually got this picture from eBay, and they sell you more than one condom because they're anticipating if you need to buy it for home use, you're going to need more than one, because it's not something that just stays real perfectly on its location on the penis, especially as men get older. You know how things are, guys. I don't think I have to explain it to you. But the goal of both of these products, both of these external catheters, is to prevent incontinence so we don't get some skin breakdown and to lower our risk of UTIs, just so you understand what they're there for. So let's talk about elimination from the bowel. And as you know, the organs involved, your small intestine, your large intestine, the rectum, and the anus. This is where our food digests and where feces form. We do have to sometimes assess people and assess stool. You look for the frequency, consistency, color. Ask people when the last time they went to the bathroom is. This can sometimes be problematic as people get older, they're more at risk for constipation. So I'm going to tell you a little bit about some testing for stool. The ones I'm going to talk about here are a guaiac, and it's also known as a blood, fecal blood, or occult stool test, colonoscopy, Cologuard, um, with, and some things they're looking for here. They can send a stool specimen over. Some other diseases, there's cancer, ulcerative colitis, several diseases I wrote here that come with stool. Most of you know C. diff. If you're not in healthcare and you don't know what C. diff, I'm going to explain that too here on a slide for you. So I'm going to start first about the term C. difficile toxin or C. diff. Most people just say C. diff. So let me explain this to you. C. diff is short for a big long Latin term, Clostridium difficile, and it's a bacteria. It's a bacteria that causes diarrhea and intestinal conditions, and I mean really bad diarrhea, okay? Like they go to the bathroom like 4 times in half an hour and the odor's so bad you can smell it all the way up the hall. So what is going on here? Well, what happens is people who are taking antibiotics or have weakened immune system, maybe they've been on a ton of antibiotics for whatever reason, that normal bacteria that regulates everything down in the colon disappears and the C. difficile toxin takes over. Okay, this is a real common cause of stool infections in healthcare settings. I can tell you that a regular hand sanitizer will not kill C. difficile toxin. You have to wash your hands with soap and water. So that's a big thing. We need to stress hand washing. I can't believe in this day and age I still have hand washing questions for students, but yeah. I mean, and you know, this is crazy. Stopped into Gecko one morning for coffee. I don't remember if I hadn't grabbed my coffee. I says, I'm just going to run here and get a coffee. Go to the bathroom while I'm there. And the sign there says, all employees must wash hands. To me, it's just natural to wash my hands if I went to the bathroom. But I guess they have to post a sign that all employees must wash hands. And then the whole time I'm making my coffee, I'm thinking, why did they have to put that sign up? But some of you who know me, I had a little bit of a sense of humor. I was trying to think if this is funny or not. But it's something to think about. And so the big thing that we've put a push on here is to try to get the C. difficile toxin treatments and things under control. They do now have something called a stool transplant. If you want to read an interesting story, look it up online. I won't go through it here, but they've been doing it for some time here in Northeast Ohio to try to cure people of this particular problem. I actually met a lady. I was running some errands for my son. As you know, he's in mechanics, and I dropped the paperwork off. She goes, "You're a nurse? Did you ever hear of a stool transplant?" And I said, "Yes, I have." I said, "Were you sick?" And she said, "Yes, I was." So I don't know what happened. I didn't ask anymore because I really didn't know her that well. I have that face that everyone starts talking to sometimes, or I start talking to. But there is a stool transplant, and this one must have been very, very sick for her to get it. But you must wash your hands. Actually have had. I hate to go on like a nut about this, but I'm out one week with you guys, and we find out someone has C. diff the one day. We have certain kinds of precautions for C. diff. And so we want to make sure we're not getting on our clothes or anything. So, you gown and everything. And the next day the weeks we come in, the next room has C. diff. So I know what probably happened. Somebody came out and didn't get their hands washed really, really well. And they're just going down the hallway, room to room. And they have to document that now in facilities. If they're in a facility and they have an outbreak of C. diff, they have to kind of document that and monitor that and get that to stop now. Kind of put a kibosh to it. So just just a little tidbit for me about this. And if you check for C. diff, it's just a stool specimen that you send over. Stool specimen is not sterile. You get your gloves on, you put it in a little cup, and you label it, and you get it over to the lab. So this is a card for fecal occult blood testing. So if you ever you can actually do a fecal occult blood test. If you think you see blood in stool, you don't necessarily need an order. But what you do is you get this little green card, and they usually come in a box of 100. Okay, and it's probably about the actual size that is on the screen, and you lift this little door right here, and there's two little things here, and you take the little stick and you rub the stool, and you put a little bit of stool here, and then you have a developer there that will tell you if there is blood in the stool or not. Um, this is not the most diagnostic thing you can do, but if you suspect blood, it's a good way to kind of go and see if there is some blood and see if your patient needs a little bit more follow up. So let's talk about colonoscopy. It's a medical procedure where the doctor takes a thin tube. It has a camera on it, and he goes into the colon and rectum looking for disease. He's looking for polyps or cancer, colorectal cancer, looking for ulcerative colitis or Crohn's. He can also look at other GI symptoms. It takes about 30 to 60 minutes. They have to put you under for it, under sedation. There is a kind of a nasty prep for it. They now have a pill you can take, but most people have to drink this big container called Go Lightly. And that's basically what it does is it makes you go lightly. They recommend you start to get these after the age of 50. I have been reading some information that they're starting to recommend younger people get screened because they're seeing colon cancer in younger people. So it's kind of something to think about. But most people, if they're not having a problem, can have these every 3 years. And most people don't like to go in. This is not the most fun test to have. The prep is the worst part. So you kind of sometimes have to talk to people about preventative health here in the United States. We really don't have preventative health, and people don't like to go in for those kinds of things. So, a little bit about the uh, Cologuard stool testing. Cologuard is a non-invasive stool-based test used for colorectal cancer screening. For anybody around age 45 and older and they're under average risk, it's looking for DNA alterations in the presence of blood in the stool. We now know that there's multiple cancers. It's like people go, why can't they make a vaccine for cancer? Because cancers are all different, and there's a ton of them. There's like thousands of them. So what a Cologuard is looking for is looking for alterations of DNA that we know that are with a colon cancer. It's about a 93% effective rate. It does not always tell you if you have polyps. It's convenient because you can do it at home and mail it to a lab for analysis, and the person doesn't have to have bowel prep or dietary restrictions. Or if it's somebody who can't get off work, they can go and do that and kind of get some kind of screening every 3 years, so we can kind of improve the health of our patients and our loved ones. So a little about colonostomies or ileostomies. So A colostomy is a surgical procedure. It creates an opening, what they call a stoma, in your colon and brings it to the surface of the abdomen to allow stool to exit the body and go into a pouch. So why would they do that? They do this when normal passage of stool through the rectum and anus is not possible due to disease, injury, other conditions. I've seen them done for cancer, for ulcerative colitis, for injuries in an accident. A colostomy is done lower near the colon. An ileostomy is done up higher where it's a little more liquidy stool. You have several things in your modules that tell you about how to empty these. If you've never emptied one, they really have a stronger odor, and I don't know if the odor is actually stronger because they're emptying the colon a little bit higher or because it technically is just right under your nose now. And this is not something that people deal well with. I mean, and the one thing that you have to be honest with patients if you go in to empty it, if I need a mask, I tell them I wear a mask for their benefit, but I'm wearing it so I don't gag. I gotta know that I respect them and that they want to do it. And I've had some patients just die of embarrassment after having had this done, and they would wake up. Maybe they kept them overnight, and they weren't expecting to stay in the hospital. I worked in an area where people came that worse thought they were going to go home, and we had to keep them. And they found out they had to have a colostomy if they weren't expecting it, and they're just have this look on their face that I don't know what I'm going to do. I don't know if I can care for this. Like, well, we have nurses who can train you, who have one, who can show you how to use this. But the overwhelmingness is stool, and we do live in a world where we don't talk about those things. So it's a little difficult. Now, I can tell you if they come from surgery and they stitch their rectum closed, it's permanent. If they leave the rectum open, they have ability to actually put your colon back together and give it a rest. Sometimes they're resting a person's colon. So there's a lot to go on with this. You can irrigate this. You can change the bag on this. These are all skills that you should be learning in lab. And you got to remember, you can have breakdown around this ostomy on your stomach, just like you can have breakdown around your rectum from stool. Stool is kind of strong, so kind of pay real good attention to that because that's kind of a skill everybody kind of needs to know. Keep in mind that you can also can have a stoma for urinary elimination in addition to stool. And if you have a urinary elimination stoma, that's a urostomy. Urostomy is a surgical opening on the abdomen that allows urine to exit the body after the bladder's been removed. They use a piece of the small intestine to make the little conduit to come out. But right here, I have given you in the picture, in addition to the information, what the stoma kind of looks like when you assess it. And on your left, they show the stoma, and then on the right, they show it with a bag. And this stoma, when you look at it, you have to kind of assess it. It's like a beefy red. And when we say beefy red, the only time I've only heard beefy red used twice in my whole nursing life. Once to describe a stoma. You wouldn't want it to have any blue around it. That would mean it wasn't getting any blood. And the other time is beefy red if a tongue is beefy red. It's a problem with iron. So it's something to kind of think about. Changing this bag is a skill if you get a chance to do it. Take advantage of it. If you need to wear a mask in clinical, just with the mask. I have to wear a mask. It's part of my nurse training. I'm lying through my teeth. And I always talk to patients, how are you doing with the odor and doing with the changing? It can be overwhelming. And that's where you use a little bit of your therapeutic communication. Tell me how you're feeling. Tell me what you're thinking. Tell me what's going on. How are you handling this? I would want you to ask me if it were me how I was handling it because I'd probably be freaking out. So just kind of think about that when you talk to people. So last topic for this particular presentation, and going to meet my goal of not going over 25 minutes for a lecture. And 20 slides is to talk about enemas. If you please look at your skill in your module book and about how to give an enema. But an enema is the process of introducing liquid into your rectum to cleanse the colon out or to stimulate a bowel movement. It can also be done to deliver medication. There's a certain position they use kind of a left lateral Sims. It's very difficult for a lot of people to hold a full enema in. Now most enemas now they're disposable. We used to do a thing called a soap suds enema. I don't know that they still even do those, but think about this. If for a while I didn't have a dishwasher and you wash your dishes by hand, if you don't get all the soap off, it'll give you diarrhea. Soap will cleanse your colon out. So we would put soap in a little bag, Castile soap, and use that as the enema to rinse people out. And it was very, very effective. And the reason they got away from using enemas a lot is it kind of depletes your electrolytes, but occasionally you do still give one. So it's kind of good to know how you're going to give that. But please take a look at that skill. I'm not doing the skills here in this presentation. It's going to probably take me an hour. So you have to keep those two different, but realize that they do go together. Thanks for listening today.